turn that off when you're done, actually. Thank you. Prevent the feedback.
Hey, everyone. Welcome to our first grand rounds of the year. We're just going to go ahead and get started. Happy to have everyone here. I think everyone may still be a few people trickling in, but let's just go ahead and get going here. So thanks everyone for being here. We're very happy to have Kyle Ridgeway here today. He's one of our senior physical therapists at UCH. Has been heavily involved in a number of research projects over there. What is really interesting and something that we're happy to be following up on today is this medical ICU research project focus on early mobility in the ICU. And Kyle's going to give us an overview and an update today, and we're very happy to have him. So welcome to Kyle.
Cool, thank you. Volume okay for everyone? And volume okay for you? So goal today is obviously I'm going to talk a little bit about a project that we've been doing at UCH for close to 18 months now that started out as a pilot at our hospital, and talk a little bit about some of the current research that's come out relating to early mobility and early rehabilitation, specifically within medical ICUs, but in ICUs in general. And then I hope to compare and contrast the two so that we can put some of the more randomized control data into the context of what we actually did clinically, which is a little bit different. This is a picture of our old medical ICU. No, I'm just kidding. This is an artist who goes around to old psychiatric hospitals and takes really grotesque pictures. And the reason I put this up is that I want to read a quote. For 3 weeks I was held in a room. I was tied to a bed if I tried to get away. I couldn't talk, I couldn't eat, I wasn't even allowed to sleep. Groups of people would enter the room and look at me and talk about me. And I was sometimes undressed in front of a small crowd. I was shot full of drugs. I was too weak to move. I could not see my body, but it had been cut nearly in half. Insects crawled on the walls and ceilings. That sounds like the quote from a torture victim, and it very well could be. But it's actually a quote from an ICU survivor who spent 3 weeks in a medical ICU with sepsis on a breathing machine and actually developed acute delirium. And the reason I start with that quote is to bring some humanism into some of the data we're going to talk about today, that this is a very real thing that these patients are experiencing. So if we get critical illness, unfortunately, we're really talking about a very heterogeneous thing. There's a lot of diagnoses that go into being critically ill or could go into being critically ill, which makes it, I think, sometimes hard to put the data into context. As well as there's a lot of personal and environmental factors before someone comes into the ICU, while they're in the ICU, and after their ICU that may contribute to some of the outcomes of problems or even successes that we see. So this is inherently a very complicated subject. So I'm going to apologize up front because what I'm going to present as far as background is a very 30,000-foot view. There will be some specifics on some specific diagnoses, but it's really hard to provide really in-depth information on all the diagnoses that may be encountered in an ICU. So I apologize up front for that. I figured we didn't want this talk to take 3 days. An hour was probably enough. We look at sequelae and outcomes following critical illness. As early as the early 2000s, it was starting to be recognized that if you looked at cohorts of patients who survived acute respiratory distress syndrome and required mechanical ventilation, that 1 year after hospital discharge, these patients had very mild and stable impairments in their pulmonary function tests and lung function. What they had is actually a lot of extrapulmonary symptoms: weakness, persistent physical disability, pain, and impaired quality of life. Now, if we've looked at these patients 5 years down the line, and these two papers were actually a follow-up on one another. So the 5-year data, they actually had an 86% follow-up rate for everyone who was still alive. The folks who passed away declined to actually do the physical testing, unfortunately. But in any case, 51% reported symptoms of depression and anxiety, and only 75% had returned to work. And this is a cohort that was fully physically, functionally independent before their hospitalization, and all of them were working. So half a decade after surviving acute respiratory distress syndrome, only 3/4 had actually returned to work, and half of them reported depressive symptoms. This is a pretty remarkable finding. Now, acutely, there's been a much bigger focus on the fact that people can actually acquire neuromuscular dysfunction within the ICU. So to get some terminology kind of fleshed out right at the beginning, ICU acquired weakness is technically a clinical diagnosis, and it is characterized by the development of weakness after the critical illness. It's general and relatively symmetric, and all causes related to the critical illness have been excluded. In addition to that, the person has to have a medical research council strength sum score of less than 48 on 3 upper and 3 lower extremity paired muscle groups. So basically less than an average of 4 out of 5, or dependent on mechanical ventilation. So this is an interesting one too, where a patient can be clinically weak, they may test strong, but if they're dependent on mechanical ventilation, technically that person can have ICU-acquired weakness. Just a brief snapshot of kind of the MRC total there. So ICU-acquired weakness would be anything less than 48 out of 60. Now the other nuance here is this needs to be done twice at greater than 24 hours apart. So this isn't a vacuum measurement. Now, obviously, getting a good clinical exam on a patient who may have sedative drugs on board, may be delirious, is hard. So most papers that actually study this qualify it with in an awake and cooperative patient, and that's about as far as they get in defining that. They don't give a RASS scale. They don't give any other kind of specifics on what they mean by an awake and cooperative patient. Now, if we look at ICU-acquired weakness, there may actually be some specific subtypes as far as a critical illness polyneuropathy, a critical illness myopathy, or a critical illness polyneuromyopathy. Most of the data suggests that when this occurs, it occurs concurrently. But again, patients can actually have ICU-acquired weakness and have no electrophysiologic changes. So there's a lot of overlap here between kind of what can happen neuromuscularly and what can be seen clinically. Unfortunately, ICU-acquired weakness is associated with worse outcomes. So if you take a look at ICU-acquired weakness is associated with prolonged mechanical ventilation, increased hospital and ICU length of stay, and actually increased mortality. Now, the assumption that sometimes people make here is that somehow the weakness is contributing to this, but this is probably actually a two-way street in that patients who are more likely to die are probably more likely to be weak. The longer you're in the ICU, the more likely you are to be weak. If you're likely to be dependent on mechanical ventilation for a prolonged period of time, you're probably more likely to be weak. So the chicken and the egg here is actually relatively unknown. That being said, one of the modifiable risk factors for ICU-acquired weakness is actually bed rest. And if you look at bed rest in an intensive care unit, 1 day of bed rest will actually result in a 3 to 11% strength decrease if you compared the patient's strength score to norms. And that holds up for 2 years outside of being discharged from the ICU. So in other words, every day that that patient has bed rest will actually predict them being 3 to 11% weaker per day up to 2 years after hospital discharge. And that weakness is associated with significant physical limitations as well as depressive symptoms. And this was actually a pretty nice study that was done out in the Baltimore area, and it was done in 13 different ICUs. So this was across a lot of different ICU types. Unfortunately, the sicker our patients are, the more likely they are to be weak. So these are some risk factors and associations with ICU-acquired weakness, and they include sepsis and septic shock, questionable role of if you need vasopressors for any reason. That has been kind of seen off and on. It's questionable whether the mean dose of corticosteroids is associated with the development of weakness. Questionable whether number of days of hyperglycemia is, multi-organ failure, prolonged mechanical ventilation, and difficulty weaning and liberating from mechanical ventilation, again, are all associated with or predictive of ICU-acquired weakness. And again, these things probably go together from a pathophysiologic standpoint. Now, if you look actually at long-term neuropathy and myopathy, so patients who have long-term electrophysiologic changes, the biggest predictors are actually how old you are, how long you're in the ICU, and whether or not you need prolonged mechanical ventilation. For actual long-term physical impairment, so patients who actually have physical impairment, duration of bed rest, age, ICU length of stay, and depressive symptoms are actually all correlated or predictive of long-term physical impairment. So we're starting to see a theme here. We're also starting to see some other things crop up. And those are things that are outside the physical functional realm and start to drift into mental health and psychology. Unfortunately, patients' issues don't stop there. So for patients who are critically ill, there's actually a high rate of neurocognitive impairment, actual measurable neurocognitive impairment. And if you actually look at one cohort of 821 mixed medical surgical ICU patients, at 1 year, 50% had testable memory problems. At hospital discharge on some certain measures, they actually tested like they had moderate brain injuries or early stages of Alzheimer's. That's how impaired cognitively some of these patients can be. Some of the risk factors and associations with these are delirium, sedation, and delusional memories. Unfortunately, sedation is also predictive of developing delirium, so there's some interplay there as well. Fortunately for psychological sequelae actually developing true psychopathology, not surprisingly, if you come in with a premorbid psychopathology, you're likely to leave one. We've yet to meet someone who came into the ICU with major depressive disorder and left feeling pretty good, but we're working on it. Unfortunately, our young females don't do as well, and again, sedation, delusional memories, early frightening memories, lower education, baseline disability and unemployment, and baseline comorbid medical conditions also are predictive or associated with developing psychological issues. For PTSD specifically, basically the same thing. The longer you're in the ICU, if you have psychopathology at baseline, if you receive sedation, especially benzos, these are all associated with the development of PTSD. So if we kind of take this body of literature in aggregate, what we kind of see is that if you look at diagnoses or patient types that are likely to have poor clinical outcomes functionally in the long term, it's patients who have acute respiratory distress syndrome, patients who require mechanical ventilation, especially those who require it for more than a week, patients who have sepsis or septic shock, multi-system organ failure, patients who develop delirium, or older folks, as well as patients who have a poor functional status before. Again, we've never seen someone come in who only walked 10 feet at baseline and they walk out of the unit walking 1,000 feet. And then again, bed rest within the ICU. There's actually been some work to actually stratify some risk groups and actually look at, okay, if we look at a lot of different factors, can we actually look at what patients' FIM scores will be down the line? And this has been done on really small cohorts of patients as far as in the hundreds. So if you look here, kind of our highest risk group are the folks who have the highest age and are in the ICU the longest. Those are the patients who kind of leave or appear the most disabled in the long term. And this is on the functional independence measure, of course. Whereas patients who are young and have a shorter length of stay seem to do better. This is one of those studies that just kind of confirms intuition. It's not that insightful that this is kind of what we would find. This is what we would expect, right? This is what we would actually probably tell people if we had to tell them. So all of this kind of culminated in the development of what was termed post-intensive care unit syndrome. I take issue with the labeling in a little bit, but I'll hold off for now. I'm trying to keep my dissent to at least 10 or 15 minutes into the talk. And this is, unfortunately, doesn't just extend to the survivor, it extends to the family as well. So if we look at the mental health of family members of ICU survivors, they can have anxiety, they can have PTSD, they can have depression, they can actually have complicated grief, as if they were dealing with the patient dying, but what they're dealing with is a new family member or friend or social support who is remarkably different than when they came into the ICU, physically, functionally, cognitively, and probably psychologically as well. This is another quote from a different ICU survivor. And he says, "It's been 2 years and I'm still trying to sort out what was real and what wasn't. I still think about it several times a week and continue to ask questions of my family. I have a compelling need to know what happened to me." So Dr. Margaret Herridge, who's a physician who does a lot of research on this from a more public health lens, really says that this is really a huge public health catastrophe when our ability to save people in critical care environment far outpacing our ability to help them live with a new disability. And she thinks that this is a very important message, not just for patients and families, but other care providers, as far as primary care physicians, and I would even say rehabilitation settings who may encounter these folks down the road. Because there can be this assumption both from patients, families, and even providers that, well, we saved your life, you're alive, that's good, and the patient can assume that they should be well. Well, I should be how I was before. or I will get back there. And the data robustly illustrates that that's probably an unrealistic expectation for a lot of these patients. Some of the more recent clinical trial data suggests that even with early intensive intervention, that may not be possible. So this is a really, really big message. If we look at all of these interactions here, and if you kind of look at quality of life backwards in kind of a physical standpoint and quality of life backwards from a more psychological standpoint, there looks like there's some places that we can intervene acutely within an ICU to kind of stop some of this. So if immobility is a risk factor for neuromuscular impairment and physical impairment, this sounds like kind of a physical therapist wheelhouse. This sounds like something that we could be pretty good at intervening on. It's also kind of been shown that if you have neuromuscular impairment or you are weak, that is going to actually preclude you being liberated from mechanical ventilation. Same thing with immobility. So maybe we may actually have an effect on how long someone stays on the vent just based on our interventions, excuse me. Now when it comes to anxiety, pain, delusional memories, things like that, because of the process in therapy and mobility, I think there's actually some ability to intervene here. If you talk about waking someone up, engaging them in their environment, having them participate in mobility, functional activity, exercise, whatever it may be, that is a cognitive task always as well. So we don't even have to think about it. We can be ignorant to the mechanisms and we still may have some effect here. So really we're talking about a really big problem here. And really if we look at all this, these are rehabilitation problems, right? These are not problems that intensivists take care of. They're not things they're going to treat directly, right? These are things that we see as therapists, as PM&R physicians. These are things that you would see in different rehabilitation settings, right? And actually, if you really look at all this stuff, these look like brain-injured patients. These look like neurologic patients. These look like patients with chronic cardiac and pulmonary disease. So, obviously, the thought was, let's get in there and let's actually move these patients around. And so in 2008, a nice kind of not randomized, but quasi-randomized study came out, and what they did is they did a protocol of early mobility. And what they found was that, unsurprisingly, you can get patients out of bed sooner, and when you get patients out of bed sooner, they seem to stay in the hospital for less time and be on the ventilator for less time. The first kind of larger scale RCT, which in grand scheme of RCTs was actually very small, about 120 patients, where they randomized patients to get early physical and occupational therapy or standard of care, actually found that they could start first therapy session within 36 hours of intubation was the first time that therapists on average went into the room. The average time from intubation to actually being out of bed, standing, things like that was 1.7 to 3.2 days, if you see that on the left-hand side. So these patients were getting up early in their ICU stay. Within 24 to 72 hours, these patients were on their feet. Whereas if you look at kind of standard care, the control group, this was more on the order of a week. And what's really interesting is that all these functional milestones kind of happen around the same day, which to me suggests the patient was extubated. Someone finally said, this patient looks a little weak, we should probably get a therapist in there. And the patient sits, stands, progresses to all these mobility milestones right around one 24-hour period. Interesting thing, if you look at the percentage of patients who were independent, functionally independent via the FIM, is the red arrow signifies the average ICU length of stay. That's the only setting they did the intervention in. Once patients went to a floor, went to an LTAC, went to a SNF, they didn't follow that. The only time that they intervened with control and difference between the two groups was in the ICU. The average ICU length of stay was right around 8 days for both groups. You can see that for some reason, potentially the effect of the intervention actually doesn't show up until much further down the line at about hospital day 21. Then you start to see this unpairing of the two groups in regards to what percentage of patients actually reach functional independence. And that actually carries out over 3 months after hospital discharge at 100 days after being out of the ICU. So is it safe? The first thing when we do anything in critical care, people are going to say, is it safe? Because obviously if you're talking about moving around patients who are on pressors, mechanical ventilation support, people are going to start to get a little bit nervous, I might say. In any case, this is prospective tracking of PT sessions from Johns Hopkins over about a 30-month period. So they had 1,100 patients that participated in over 5,000 PT sessions delivered by 10 separate therapists. They had exactly 34 predefined adverse events, and these adverse events were a heart rate greater than 150 or less than 50, a MAP greater than 140 or less than 55, SpO2 less than 85% for more than 3 minutes, fall to the floor, removal of any line or device, cardiopulmonary arrest, of course, new onset of an arrhythmia. And of those 34, only 4 required further intervention. So what they did is any time the therapist, after every session, had to fill out a sheet that signified whether or not one of these things happened. If it did, a pulmonary fellow tracked that patient's case for an entire week and made a delineation on whether or not that event led to more intervention, and then they made a delineation on whether or not that event led to increased length of stay or cost, which it did not. Most of these events actually were a new onset of an arrhythmia. So let's get to UCH, get to what was kind of happening in our hospital contextually. So in 2007, a physical therapy consult was less likely in the medical ICU than it was in any of our other ICUs for patients who require mechanical ventilation for more than 7 days. So we're not even talking about acutely sick patients who are on the vent for 2 to 4 to 5 days. These are patients who have been on mechanical ventilation for a week or more, and there's a remarkable disconnect in our consultation practices between service lines and ICUs. Our surgical ICU is now our cardiothoracic ICU, but you can see there that if you were on the vent for more than 7 days, pretty much you were going to get a consultation, or we were going to get a consultation for that patient. In the MICU, it was below 60%. You basically had a coin flip chance. Interestingly, having a PT consult, not even what we did. So you take me in 2007, when I've just started PT school, you just drop me in the ICU that is somehow independently associated with an improved discharge status. So just having that consult on your chart 3 times more likely to discharge home. The argument here would be that my critical care physician colleagues are really, really good at picking which patients would respond to therapy and discharge home. I'm not quite sure we can say that, but that would be one critique of this data for sure. If we look at staffing or kind of what the layout looked like, this is a very rough contextual layout of what one physical therapist was expected to cover or had to cover in a single day, Monday through Friday. So our old medical ICU was 17 beds, but it was 2 pods separated by a hallway. And this is going to be important later. That same physical therapist also had to cover our surgical ICU, which is 18 beds and 1 really long hallway with a narrow hallway between it. These 2 units are in separate buildings. So for those of you that were at UCH back then, the medical ICU is kind of out over in the corner. The surgical ICU is in the critical care wing kind of near the OR. So this is a walk away. So basically what you had is you had 34 ICU beds, 2 buildings, and 4 pods. So even on the best of days, this is a difficult logistical thing for the physical therapist to cover. Not only that, if you can think which one was the squeaky wheel of who wanted the physical therapist in their unit, cardiac surgery or the medical ICU. So I can remember days that I didn't step foot in the medical ICU for days on end. Not because I didn't want to, but because of how much demand there was for our services and our presence in the cardiothoracic surgical ICU. Now, when we built our new tower, things changed a little bit. We had basically, on our 10th floor, we had a 36-bed med-surg progressive care unit, or kind of mixed step-down unit. And then the NICU became a 24-bed unit that's kind of in a square. Normal staffing was around 2 physical therapists Monday through Friday to cover those 60 beds. Now, we would have to share the load. So again, I can remember times when I would not go to the medical ICU because of the demand, discharge pending, other new consultations we had in the progressive care unit. So really, on average, what we kind of estimated is that the medical ICU probably had about a half physical therapist Monday through Friday. If we look deeper into kind of our historic practice, if we look at ICU admission to first PT session on average for the patients who got PT, For all comers in our medical ICU, the average time from admission to us getting in there was 3.7 days. If you required mechanical ventilation at any time point, that average was actually 6 days before we would actually be in your room and doing an evaluation. Most of the research that we looked at, most other quality improvement projects suggest, as I mentioned, that you can get in the room within 1 to 2 days. 24 to 48 hours is feasible and safe to start therapy. Our length of stay for mechanically ventilated patients in our medical ICU historically was 9.6 days. For patients who did not require mechanical ventilation, it was 4.6 days. So there's a difference there in patient populations that we think is clinically and actually research-wise significant that I'll talk about later. Again, we had maybe a half therapist 5 days a week, absolutely no weekend coverage. I cannot remember a time ever stepping into the medical ICU on a weekend, unless for some reason that patient was going home and needed a PT consult. Of all comers into our medical ICU, only 28% of patients ever received therapy in the medical ICU, so less than a third. Of those that did, they received therapy on only 44% of their ICU days. So less than half of their days being in our medical ICU did they ever receive therapy. So if you look at both percentage of patients who were seen and the frequency at which we were seeing them, this is not intensive, early, nor frequent. And I think we can all agree on that. Again, if we look to both the published research as well as other quality improvement projects, it seems very feasible that 80% of a medical ICU at any given day can participate in therapy, and that therapy can be actually procured. They can actually participate in therapy on 70 to 90% of their ICU days if it's done in a proper way. Most, again, projects or research that we looked at prior to this suggested that you can decrease ICU length of stay somewhere between 1 and 2 days absolutely, or 20 to 33% relatively by instituting such a program. So what we proposed, multiple iterations. We actually ran our project on 50% of our initial proposed budget because welcome to healthcare. So we had around three therapists staffed only in our medical ICU Monday through Saturday. So we were able to advocate for 6-day-a-week coverage. What we did is we built in a PT consultation as an automatic part of the MICU admission order set. The reason we did this was in our medical ICU, we have a closed unit, 24 beds, 4 teams, 2 attendings, 1 pulmonary fellow, and way too many residents to keep track of. Those residents rotate on God who knows schedule. The pulmonary fellow stays for a single month. The attendings rotate every 2 weeks. So even in talking to the MICU service, they thought logistically, let's take out the problem of procuring the consult. Let's make it an automatic part of the admission order set. We trust you guys with the training that I'm going to talk about to triage on the back end and then come to us when there's problems. Other programs have taken a reverse approach. Let's protocolize when we will consult therapy and educate everyone on what that looks like. Again, one of the reasons we did this, it's a little unique from other programs. We didn't have a physician champion. We had physician support. I don't want to at all communicate that we didn't have the support of our medical ICU and critical care colleagues, but we didn't have a singular physician who said, I'm going to help head this project. This is my baby. I'll be the kind of the figurehead or the person running around the unit with the pom-poms. And there's a lot of reasons for that. A lot of our attendings are involved in a lot of research. So we don't have a medical director who just kind of lives in the unit. Some other academic hospitals, their medical director, their office is literally right in the MICU. So again, and with talking with the medical ICU attendings and the critical care service, this is actually what they preferred. They said, this makes it much easier for us. I love this. I don't have to think about it. You're there. You're consulted. Awesome. Great. One of the other things we built into this because of that was we decided to formulate our own rounds as a physical therapy team. So we actually did walking rounds on the entire unit every single day, not always on Saturdays, depending on our staffing. Again, the reason we wanted to do this was twofold. After training, this made it very, very easy to collaborate and continue to improve our clinical skill set because we were actually rounding on patients every single day. This is remarkably novel in physical therapy. I know to you guys this probably seems like, duh, no-brainer. I would have built that in day one. This does not happen outside of a rehabilitation unit in any acute care hospital that I'm aware of. It's not a part of our practice because of productivity requirements, because we're all very sensitive, because we're therapists and we don't want to argue with each other. Just there's a lot of reasons why this stuff doesn't happen. What we also did is that in that unit, case management, social work, and the charge nurse would have a half-an-hour rounds on every single patient every day. So we wanted one of our physical therapists to attend those rounds to help with discharge planning, get some updates from the charge nurse, that type of thing. We also did very extensive pre-implementation training. This doesn't sound that extensive, but again, for physical therapists in acute care who are trying to do this, this is actually pretty extensive. So what we did is we had 12 hours of PT to PT training. That was kind of broken down into 6 2-hour sessions. We had a 4-hour class with RNs, or a nurse educator and the associate nurse manager, teaching the anatomy and physiology of all the common lines in the medical ICU, teaching medical ICU logistics as far as spontaneous awakening trials, breathing trials, different protocols, also giving us kind of some background on some pathophysiology of sepsis, ARDS, and pharmacology on some of the common medications used for anxiety, pain, and blood pressure support. The other thing that was unique about this is that the coordinator of the project was a physical therapist, and 50% of their time, my time, was administrative. So I could work on data design, data analytics, going to meetings, co-treating with other therapists, doing more trainings, things like that. Programs that have coordinators at other hospitals are usually professional research assistants or research assistants who basically have a checklist and just go around and try to procure consults based on a protocol. Again, the reason we wanted to do this is not having a physician champion who could kind of champion this. We wanted to actually have some strictly budgeted in time in our pilot to make sure that we could address any barriers, that we could go to meetings with RT, that we could go to nurse staff meetings and make sure that the collaboration was there. So as far as clinical data collection, every single session that we go into the room, we collect the Richmond Agitation and Sedation Scale, the Confusion Assessment Method for the ICU, an MRC Strength Sum Score if they're cooperative and if they're less than 48, and kind of 3 measures of mobility or functional status. The functional status and ICU score, which if you're not familiar with that, it's basically just the FIM broken down even more detailed. So it basically takes 5 items and you score it on FIM-based scoring. So it takes rolling, supine to sit, unsupported sitting, sit to stand transfers, and ambulation. The ICU mobility level, which is just a 0 to 10 scale that grades what level of mobility was achieved during that session, and then the AMPAC 6 clicks basic mobility grading, which is something we already did in our hospital on every patient. As able, we were doing the physical function ICU test, 5 times sit to stand, 6-minute walk, other functional measures. So we were actually really trying to capture a lot of clinical functional data. In addition, those same safety criteria I mentioned before, every single session the therapist had to assess whether or not one of those events occurred. So our goals were, and kind of a brief primer on quality improvement, everyone always wants to get to the outcome. Did you get the outcome? But in quality improvement specifically, you have to show that you changed practice first before you go to the outcome. So we very explicitly set our clinical goals to be decreasing the time from MICU admission to first PT session, increasing the number and percentage of patients participating in PT, and increasing really the frequency of PT. We couldn't really quantify the intensity specifically, although we could kind of proxy it based on observation. And then the duration turned out to be too messy of a metric because of how many really short sessions we had and how many really long sessions we had. So the average actually turned out to be the exact same over time. As far as outcomes, because hospital administration was paying for this, what they really wanted to know was how much money did you save us? And I joke about that, but this is really what it was sold on. This project never, and I can't stress this enough, never would have been approved if we did not have a business plan and a business model that predicted cost savings in almost every single scenario. So the big thing we had to look at was length of stay, potential cost savings, and then of course, happy customers. We wanted to do patient perceptions of their physical therapy experience. We were lucky in that we got to use a survey that had been used in a RCT that had been conducted in the Denver area. So that was already constructed for us and very easy to implement. Kind of a brief summary, and then we'll dive into the details. Over the course of 9 months, we had 2,622 total PT sessions in our medical ICU. 784 of those involved patients who were on mechanical ventilation at the time of the session. 18% of those mechanical ventilation sessions involved standing or greater level mobility. So in other words, if one of our therapists in our MICU program walks into a patient's room who's mechanically ventilated, there's a 1 in 5 chance that patient will stand up. 67% of all MICU admits receive PT. That may seem a little low, but I'll illustrate why in a minute. The time from MICU admit to first PT session for all comers was 1.3 days. If you required mechanical ventilation, 2.0 days. And we had a remarkable decrease in length of stay for patients requiring mechanical ventilation. So they had a 1.4 day decrease in their ICU length of stay and a 2.2 day decrease in their floor length of stay for total hospital reduction of 3.6 days. And patient perception-wise, is they rated it as very hard, not surprisingly, but they had high satisfaction, high engagement, and actually, interestingly, felt very involved in their care is one of the things they reported. So if we look at the admits during that time, we had right around 1,400 admits into our ICU during that 9-month period. 310 of them required mechanical ventilation. Around 1,100 did not. Of the ones who required mechanical ventilation, 88% of them received therapy at some point during their ICU stay. Of the ones who did not require mechanical ventilation, only 61% received therapy at some point during their stay. The question that always comes up here is, why is that number so low? Demographically, 50% of all admits to our medical ICU stay for less than 48 hours. That's not really a population we're trying to target, and we will see them if it makes sense. But a lot of those patients have rapid reversible problems, and they're in and out before we may even kind of be on their case. And that totaled 2,622 PT sessions. Again, of those sessions, around 30% of those sessions, the patient was on mechanical ventilation at the time. Most of those sessions, and those numbers should be switched there. That shouldn't be a 9, should be 4%. Most of the sessions, when patients were on mechanical ventilation, they were mechanically ventilated through an ET tube, so they had an endotracheal tube. Only a very small percentage of the sessions were patients actually mechanically ventilated through a tracheostomy. So of all total sessions, 10% of all of our physical therapy sessions involved a mechanically ventilated patient, at least sitting on the edge of the bed. Again, demographically, if we look historically, a large proportion of the patients who are admitted to the medical ICU stay for less than 2 days. A majority stay between 2 and 30, and a really small slice stay more than 30 days. And that's historic data from April to December of 2012, 13, and 14. For our analysis, we didn't think we'd see an effect for length of stay on patients who stayed less than 2 days. The patients who stay less than 30 days, that's less than 1% of all admits, and when it happens at a very big number. So they're not staying for 35 days, they're usually staying for 196 days. So it really pulls up your mean, and it's a really big outlier. So we threw those out. So for our analysis, what we looked at was patients who stayed more than 48 hours and less than 30 days. Historically, if we take that group out and we look at them, about a quarter of that group requires mechanical ventilation historically, and about 3/4 does not. And historically, for length of stay, the reason we stratified mechanical ventilation versus not requiring mechanical ventilation is it's very easy to stratify when we were pulling data out of Epic. Anyone who's ever tried to pull data out of Epic knows exactly what I'm talking about. You have better luck mining for gold in this day and age, and I'm absolutely convinced of that. So for a patient who requires mechanical ventilation, their total hospital length of stay on average historically is about 25 days, around 10 days in the unit, 15 days on the floor. If you don't require mechanical ventilation, average ICU length of stay is around 5 days, floor length of stay 7, so you're in the hospital for around 12 days. So not only is mechanical ventilation clinically significant as far as a proxy for acuity, it also seems to be clinically a much different entity in regards to length of stay. And that's been shown in the literature. If you look at ICU populations, mechanical ventilation is an independent predictor of how long they'll stay in the ICU. If we look at the demographics, the other interesting thing to note is proportionally we admitted 2 times more patients who required mechanical ventilation during our project period for whatever reason. We can't really explain that. We don't have the depth to drill in and answer that question. But interestingly, twice as many patients required mechanical ventilation during our project period. As far as other demographics, everything else seemed to be about the same as far as how long, what proportion of patients were staying in the unit in different times. So it's not like we all of a sudden saw a bunch of patients who were staying less than 2 days. The other interesting thing is we did see about a 1-day decrease in average time on mechanical ventilation. This is a graph of our length of stay over time. Again, averages are a little bit different. So we see kind of a stark, sharp decrease in ICU length of stay especially, and that p-value is around 0.02 for those of you who like to. Interestingly, we saw a decrease in ICU length of stay for non-mechanically ventilated patients, but following with a historic trend, patients were staying in our hospital longer on the floor. Again, no idea how to explain this. Some local contextual factors that we thought of was increased social work and case management strain, taking on more admissions and seeing more folks in the hospital who had no insurance, not enough insurance, or a lot of kind of psychosocial barriers to discharge. So again, it was hard to dial into that. And we weren't doing anything outside the ICU. So even to see that, that was kind of outside of our program anyways. Everything for them on the floor was kind of par for the course. So if we look here, and this is just some fancy math to try to keep your program going, but in any case, because of decreases in length of stay, if we actually look at the cost per day, and you look at the number of admissions and you times the number of admissions by the length of stay decrease, you get a number which administrators love, which is the total bed days saved. In other words, how many days did you save by implementing this? And so we used very conservative direct cost of care estimates when we did this analysis. So it's for sure conservative because we're only taking estimates of direct cost of care. This doesn't take into account staffing, keeping the lights on, all that kind of stuff. This is just the direct cost of care. We were able to get this specifically for our medical ICU, so we think contextually for our environment it's fairly accurate. But with a 1.4 day ICU length of stay decrease and a 2.2 floor length of stay decrease, we looked at a kind of a gross cost savings for the number of admits that we had at about $1.3 million. Now, we were honest, where we saw length of stay increases, we modeled that into our financial model as well. And if you looked at actually patients who didn't require mechanical ventilation, it appears that we actually cost a little bit more money to give them care during our project period, which is quite all right. We factored that in. So if we look at kind of a cost savings per patient, it looks like if you required mechanical ventilation, on average, your case cost the hospital around $5,000 less than it would in previous time because of the decrease in length of stay. Unfortunately, if you didn't require mechanical ventilation, it looks like there was a relatively nominal increase in the cost of your care, around $640, which again, given the patient problems surrounding an ICU stay, you would say that's maybe an okay associated cost to actually treat those patients. Because one of the questions we always get with this from administrators is, well, why not just see the patients who are mechanically ventilated? That's where your effect is, just see them. Unfortunately, or fortunately, with a QI model, all we know is that when we implemented this model, we got these results. We can't just cherry pick out and say, well, that's who did well, let's just try to push the treatment towards them. As well as we really think that those patients have a lot of needs as well, and the research would support that. So if we take into account costs, we're looking at a net cost savings of around $800,000 for 9 months, so around $100,000 a month. If you do the math on 6 days a week, 3 therapists, pretty much every time one of the therapists on the team walks into the ICU for a day, they save the ICU about $1,000. The net cost savings per patient is around $1,200, even factoring in that those patients stayed more time on the floor. Again, if we go back and compare to what we had looked at previously, we hit most of our goals and were fairly comparable to all the research we had looked at. So ICU admit to PT, we were right in that 1 to 2 day range, even for our mechanically ventilated folks. As far as ICU length of stay decrease for the mechanically ventilated folks, again, we were right in that 1 to 2 day range. We were able to staff on average around 3 therapists Monday through Saturday, and 67% of our patients received therapy on 71% of their ICU days. That's not bad. That 71% number, again, seems a little low, but you have to remember that every 7th day, they're for sure not getting therapy. So no one got therapy on Sunday, so that number is kind of artificially a little bit low. And then we saw cost savings that was fairly analogous to other programs. Again, I think there's a lot of very interesting things that happen in this project that the data literally cannot illustrate. And I'm going to get into some of that right now. And this is a quote from one of the medical ICU RNs, who has worked in our medical ICU for 12 years, and she's talking about Warren, one of our PTs who's here today, and working with a gentleman, Mr. M, who was awaiting lung transplant. These folks who have chronic lung disease, as many of you may be familiar, anxiety, depression, significant psychopathology as a sequelae of that or an association of that is very, very common. What we've found observationally and what I've seen over and over again is these patients come in awaiting a transplant and they are just getting physiologically worse and worse and worse, and we are just trying to hold on to them, hoping for lungs. And these patients can take such a turn into anxiety and depression where they don't want to do anything. Everything makes them anxious. They're on a ton of benzos. And slowly over the course of a week, Warren seriously slowly nudged this guy from the edge. I mean, this was a guy who was going down that road. And I mean, she was his most consistent caregiver. He was in our ICU for almost 40 days, which means residents had changed out. He had gone through 3 different attending teams. I'm sure the pulmonary fellow had rotated at some point. Warren was literally his most consistent bedside provider. And so much so that he was actually able to, unfortunately Warren wasn't there for this, but helped set it up. On his wedding anniversary, he was actually able to go to our solarium with his wife and have a meal there, which never would have happened if it was just me in the ICU. Never would have happened. Unfortunately, he passed away, but this is a memory that his wife said she will remember forever. I mean, it was that powerful for her. So if we look at the mobility data, kind of what was done during sessions, we take all comers, all sessions. 60% of all sessions involve sitting at the edge of the bed or more. 50% were standing or more. 32% were marching at least 4 reps or more, and 20% were ambulating 15 feet or more. So again, a fifth of the time, therapist walks into a room in the medical ICU, that patient's going to walk at least 15 feet. Interestingly, 14% of the time, the patient ambulates more than 100 feet. This is all comers. If we look at patients who require mechanical ventilation, most of the time what people will throw up here right now is a picture of someone walking. I'm going to go on a tangent for 30 seconds, and then I'll regress back onto the reservation, I promise. It's a great picture. I love it. Everyone loves it. Everyone's high-fiving. It's awesome to see. We've done it. We do it. This is not what this is about, and I'm absolutely convinced of this. This happens 0.002% of the time for all of our mechanically ventilated sessions that someone walks more than 15 feet on the vent. It's not what it's about. Now, that being said, they are still mobilizing at a very, very high level. Over a third of the time, they're at least sitting on the edge of the bed. A fifth of the time, they're standing. And even 4% of the time that we go into a mechanically ventilated patient's room, they're marching or further. So there's a lot of stuff happening, but it's not always that ambulation picture that everyone's obsessed with. I'm not saying it's not possible, but that's not the goal. And I'm at this point pretty convinced of that. I'll always concede to a better argument, of course, which one of my colleagues from San Francisco continues to try to convince me of. Another interesting thing, 24% of our sessions involve absolutely no mobility whatsoever. I'm also convinced that these sessions are vitally important to ensure that this mobility happens earlier. And the reason I say that is it's very, very easy to cruise by a mechanically ventilated patient's room. They're a bit sedated. The nurse says they're a bit sedated. They're a touch restless. The nurse says they're a touch restless and say, they're not ready yet today. It happens enough that you go in there and they really don't look ready, but you say, let me do a neural assessment. Let me check their range of motion. Let me check their skin. Roll them and see what happens. Follow commands. Doesn't always work out. 24% of the time, that's all we get. Nothing more. But sometimes they do wake up. Sometimes they're able to tolerate being in chair mode and doing some exercises. And every now and then, actually something better happens and they're able to mobilize. But getting in there early and risking the fact that, you know what, there's going to be some times that we strike out and the patient really truly isn't ready. Physiologically, cognitively, whatever it might be, they just might not be ready yet. But we have to start early in order to progress. And I'll give a case example of this. We had a patient who was admitted, had a non-alcoholic liver cirrhosis. She was intubated. I saw her around 18 hours after her admission and her intubation. She was a little bit sleepy, but the nurse lowered the sedative medication. She's following some commands. We got her up into chair mode. She started to wake up. She actually come into unsupported sitting. She stood up 3 times that first day. Next day, another therapist saw her. Didn't need any sedation overnight. She was totally awake, following all commands, not delirious. She actually got out of bed, into a chair, and did the PFIT. Actually did the marching on the spot testing. Sat up in the chair for a while. Day 3, she was extubated around midday. One of our therapists, a different therapist, I think, actually went in the afternoon. And that patient was able to ambulate 500 feet. This is a 73-year-old female. Interesting thing here is that maybe we had a physical effect there, but there's also the psychological effect of the patient was already ready and had been mobilizing. And the question that we talked about when this case happened, and I won't forget this because I thought it was a really, really interesting case, is I was thinking historically, what would have happened if the first time you saw that patient was after they were extubated? Well, in your mind, 73-year-old female has been in bed for 2.5 days. She was on the vent for about 72 hours. I'm not sure, as therapists, we would have walked her 500 feet, even if she was able to. Conversely, I don't know if psychologically she would have been ready to walk 500 feet. So I think there's a lot of interesting things that these sessions kind of build upon for each other. The question becomes, were we actually different? So if you look at point prevalence data from like Australia and New Zealand, they looked at 514 patients, 45% were mechanically ventilated, and for all comers, only about 40% of their folks actually got out of bed, and only about 18% ambulated. No patient requiring mechanical ventilation sat out of bed or walked. 0. And of the patients who were in the ICU more than 48 hours or had been in the ICU in 48 hours, only 14% walked, all total. In a one-day point prevalence study in Germany, only 24% of all mechanically ventilated patients and only 8 patients who were mechanically ventilated via an endotracheal tube were mobilized out of bed at all. Very, very low numbers. I mean, trending towards 0. If we look at, and this is an abstract at ATS, if you look at the acute respiratory distress syndrome network, a network of researchers and hospitals who study ARDS, they did a point prevalence study in 17 hospitals and 33 ICUs. 73% of this cohort required mechanical ventilation. Whether or not PT or OT saw you was correlated with mechanical ventilation. So if you weren't mechanically ventilated, a therapist was twice as likely to see you. PT or OT involvement was actually associated with a higher level of mobility, not surprisingly. That had been found in other point prevalence surveys that therapists routinely mobilize critical care patients to a higher level than the bedside nurse. And that's nothing against our bedside nurses. They're fantastic. Of the patients who were mechanically ventilated, only 22% mobilized and only 16% of them mobilized to a higher level of mobility. Mechanical ventilation, benzos, propofol, delirium were all negatively associated with higher mobility. In other words, those things were predictive of not mobilizing. The other interesting thing is that the institution, the specific hospital, explained 75% of the variance in the model. In other words, it really depended on where you were on how much you were mobilized. Real briefly, were we different than physical therapy practice? This is a survey that I was fortunate to participate in a while back, where we actually surveyed acute care section members of the American Physical Therapy Association. So these are therapists who work in hospitals. And we asked them, ideally, what would you do with this patient? And we had this really brilliant case where the difference between case 2 and case 3 is, in an entire paragraph, I'm not kidding you, a single word. Everything else about the case study is the same. In case 2, the patient is mechanically ventilated via an ET tube. In case 3, the patient is mechanically ventilated through a tracheostomy. Every single word, time in the hospital, strength exam, hemodynamics, vent settings, are all the exact same. As you can see here, what the therapist would do for the patient who is mechanically, case 3 is the patient who is mechanically ventilated. As you can see, as the higher level mobility starts to come up, the ET tube starts to present itself as the thing that says, no, we're not going to do this. So much so that when we get down to ambulation, If you have an ET tube, we say, everything being equal, even if it looks okay, only 31% of the time will we walk you. Oh, but if you have a trach and you look at the exact same and been in the hospital for the exact same, everything else is the same, we'd walk you half the time, 50% of the time. Same thing when it comes to vent settings. This was another very well-written case, I think. So it's been very well shown that you can mobilize patients on an FiO2 of less than 50% and PEEP of less than 10. So we said, let's give a PEEP of 10 and an FiO2 of 70% and see what therapists would do. Again, if you look at sitting edge of the bed, transferring out of the bed, all that kind of stuff, everything starts to be remarkably less. And these, I mean, this is a high vent setting. This is not that high of a vent setting. I mean, we mobilize patients on this vent setting very routinely. I mean, it appears high, but it's really, this in and of itself in isolation should not be a barrier to being able to procure treatment to a patient. This is a quote from the medical director. I had to give her a shout out, of course. We didn't pay her during this project. We actually offered. She declined. We budgeted that in, actually. The last thing I want to end with is the patient perception. So we did a survey. We only captured on about 45 patients, unfortunately. But we asked them a question, 1 to 10 Likert scale on all the questions. And if we looked at them, we said, you know, do you think PT is necessary? 9 out of 10, extremely necessary, but also very difficult and very intense on a 6 out of 10 scale. Do you think it's beneficial? Trending towards 10 out of 10. Did you enjoy it? Actually, this number is much higher than I anticipated with me being involved in this project. I thought this number would be around 5, honestly. And it was around 7.7. And they still said they would have requested more. So on the Likert scale for wanting more therapy, the 1 was you would want the same or maybe a little bit less sessions. Even 5 says I would want at least a few more sessions. 10 was I would want many, many more sessions. So even getting therapy 6 days a week, some of these folks, they wanted more therapy. And they were pretty satisfied and fairly engaged. One case study. So after doing this for a while, the nurses get good at it, the RTs get good at it, and there's 2 very interesting case studies. One is, which I think is the magic of putting a PT and an RT together. I think that combo in the ICU is a home run. In other countries, actually, RTs don't exist. It's physios who specialize in critical care. But in any case, we have patients who routinely will actually fail their weans because they're apneic, whether they're too sleepy, for whatever reason, they don't have the drive to breathe, and they fail their weans because they're apneic. We have had a handful of patients where we home run this because if you're apneic, you should wean while participating with therapy. We can come in, we can wake you up, we can mobilize you. Now we induce you to actually start to breathe. We've had many patients that we've helped bridge to extubation just based on that, or because of their poor strength or a bad cough, a lot of secretions. A couple of patients that I can remember, one of which was neuromuscularly weak, that they actually extubated in the chair sitting upright to maximize their position. The flip side is the patient who's a little restless. We had one recently. It took 2 therapists and the nurse, but we were actually able to calm him on his wean, get him to stand up a couple of times, and actually coach him through his breathing for about 25 minutes to slow his respiratory rate and get his volumes in a good place. This is something that it's not that the RTs can't do it. It's not that the nurses can't do it. I would say that we're in a much better mindset to do it because we're used to interacting with patients in that way. But the flip side is the RT is not going to stand at the bedside for 30 minutes and coach someone through a wean in order to extubate them. Especially the patient who's a RAS of +2 and very fidgety and repositioning like this, I'm not kidding you, every 2 seconds and wanting to stand up every minute. There is no way that an RT is going to do that. The flip side is the nurse may want to do that, but as soon as the patient down the hall codes or her ETOH patient tries to jump out of bed or her patient down the hall self-extubates, she has to go, or he has to go. So that was one. The other one is, as I always joke, my new favorite progressive neurologic condition, ETOH abuse. These are patients who are almost impossible to control while they're mechanically ventilated. They're withdrawing, you have to give them a ton of benzos, and they get delirious, then they get more mad. And it's always the 40 to 60-year-old males who are tough. So we have this guy, we'll call him Wild Bob. It's not his actual name, but that is part of his actual nickname. He has been admitted over 27 times to our medical ICU, so much so that a nurse who's worked there for over a decade remembers him from when he was a CNA. This is a guy who can be wide awake with a RAS of +2 or +3, absolutely agitated on 50 of ketamine, 20 of Versed, 300 of fentanyl, and getting pushes all the time. So much so that sometimes they have to put him in a phenobarb coma to have him withdraw. So one of our therapists, who's not here unfortunately, Rebecca Downey, and one of our best nurses, who's also named Kyle, also has a beard. So Wild Bob was on 11 of Versed. He was on, I think, 15 of ketamine and 150 of fentanyl, and he got an 11 of Versed as bolus over the past 30 minutes. Downey sat him at the edge of the bed. He was following all commands. He was CAM negative, so he was not delirious. He likes to sit cross-legged, so he's sitting cross-legged. Gave 2 thumbs up. Showed the pulmonary fellow. She was like, they were going to give him a trach because of how much tracheomalacia he had from being extubated and intubated so many times, and they didn't want to risk extubating him and having it not go well. It was going to be a tough reintubation. It's like, we're not going to extubate him today. I know he looks great. So the next day, he was on a little less sedation, only 7 of Versed, and needed as many boluses over the course of the day. The nurse, we call him Big Kyle, big guy, had him again. Rebecca Downey had him again. And he walked 600 feet. I mean, this is a guy that if you just looked at his chart and you gave his case to anyone and said, do you think this guy's a candidate for mobility today? Everyone, you'd say, I would be surprised if anyone in this nation, except for maybe Heidi Engel, would say, yeah, I think we'll just wait until maybe next week. He actually, I think, ended up self-extubating that day, but he didn't have to get reintubated, so that was a good one. That's just a very interesting case study where this collaboration between RT, PT, and the nursing, and once we've done it enough, everyone's kind of seen it, so you're not coming in and suggesting something so ridiculous. It's happened, they've seen it, and they say, you know what, yeah, this would be a great thing for this guy. The thing I forgot to mention is before we ambulated this guy, the nurse had already had him to and from the commode twice. To have a nurse without a therapist on their own transfer a mechanically ventilated patient to and from a commode who's intubated via an ET tube, you could probably go to ICUs around this country and never see that in the course of an entire year. And that's not exaggerating. That's actually from the data. I think one last thing. 2 recent trials came out that you're going to hear people say physical therapy doesn't work. First of all, what the hell is physical therapy? It's not a verb, it's a noun, okay? No one has ever come up that I've seen and said medicine doesn't work. What medicine? What provider? What dose, right? So you have to dive into what actually happens. So the one trial that I want to look at was a standardized rehab rehabilitation protocol, and they powered their study, I'm not going to go into this, to a 30% reduction in length of stay. That was their primary outcome for their study. Any of you who have ever looked at length of stay data, it is remarkably messy and it has multiple factors, and to decrease it by 30% is very, very hard. In any case, they randomized patients to either get this standardized rehabilitation therapy protocol or usual care. This is at Wake Forest, where their usual care is that they've done this since 2008. They were the study at the beginning that I quoted, where they got people out of bed early. That was them. So what'd they find? Basically no difference in ICU length of stay, hospital length of stay, many mental state exam and out points, ability to complete a 4-meter walk test, handheld dynamometry, SORT physical performance battery at 2 and 4 months, SF36 at 2 and 4 months, functional performance inventory. But what did they actually do? The standardized rehab was passive range of motion given by a CNA starting from as soon as they were admitted. It was 5 reps each joint. Not really sure what that's going to do, but it's okay. I'm going to let it slide here. Physical therapy was function-based and targeted towards deficits. On average, patients got 5 sessions of that in a 10-day length of stay. So 50% of their length of stay, they got some type of mobilization. And then progressive resistive exercise, which started in supine if they could tolerate it, and then they did it sitting at the edge of the bed. It was either active or with TheraBand. It was very simple motions like elbow flexion and shoulder flexion. Absolutely no standing exercises were included in that progressive resistance exercise program. Probably underdosed for the 92-year-old on the ACE unit, let alone someone who really actually needs strength training, right? So they got 3 sessions of that. So on average, these patients stayed in the hospital for 10 days. Over that 10 days, they got 8 sessions of passive range of motion, 5 sessions of mobility, and 3 sessions of exercise, probably underdosed exercise. So really, they didn't actually get that much. So again, if we look at the contrast between our program and theirs, ours, we could say is much more intense. 70% of the time, when we will see a patient who's on mechanical ventilation, they're actually going to get mobilized. Now, if we look at timing, the physical therapy on average wasn't initiated until 3 days. So we know at the very least, the average time from intubation or MICU admission till mobilization was at the very least 3 days. It was probably more on the order of 4. They didn't report that. As far as the actual exercises, 4 days. So we have no idea also about the duration, level, and intensity of mobility and mobility milestones reported. The reason that's important is, what do they compare it to? This is all that they say about the control group, with the exception of how often they were seen. Physical therapy participants in the control group will receive PT evaluations as dictated by the patient's attending physician. Follow-up sessions for the control group will occur as per initial physical therapy consult recommends. So just normal practice, and that's fine, but they did not quantify it whatsoever. I have no idea what these patients did. I can tell you right now, all of this is pretty standard physical therapy for anyone in the acute care hospital. So the likelihood of actually having contamination between these two groups seems very high. The one thing that we do know is these patients did not get a lot of therapy. On average, 1 session in a 10-day waiting stay. What is interesting, though, is that at 6 months, not all of their physical performance measures actually were either trending or were statistically significant, and the difference between the two groups met the minimally clinically important difference for that measure. So that's the short physical performance battery score there. So at 2, 4, and 6 months, the difference between the two groups was 0.91 and 1.1, with p-values of 0.05, 0.06, and 0.04. I won't bore you with the limitations of the p-value. Any of you want to jump into statistics, there's been plenty published on that. But this is a clinically meaningful difference between groups with a really low intensity, initiated late, likely underdosed intervention. But the problem this also brings up is that these patients have problems really, really far down the line. So this is a piece of data that is actually from our hospital. And what this shows is that functional independence can actually be ascertained based on electrophysiologic changes. So in other words, you take patients who have normal strength scores, but their FIMs are different. This group is impaired, this group is mostly independent. And you actually do nerve conduction on them. The patients who have impairment are patients who seem to have functional independence problems. So this might be why when we power trials to strength exams that are probably remarkably not sensitive enough to show some of these changes. And even if we look at those, even though ICU acquired weakness is important, it seems like there's something more here where a patient can be strong, they have electrophysiologic impairment, and that seems to correlate also with physical and functional impairment. There's a lot of nuance here that I think is very interesting. So, a lot of slides from some previous stuff. What about PM&R? So this is where I think why we need not just therapists and rehabilitation professionals, we actually need PM&R physicians. And I'll give another great story. Sometimes we get patients who have had brain injuries into our unit. They have a history of it and they get sick. Or we have patients who might as well have had a damn brain injury because they look like it. Intensivists love Haldol. They will blast that stuff around the unit like it is Christmas. And we've had remarkable success actually consulting PM&R and had a couple of really successful cases with Dr. Niehaus coming up, actually totally changing a patient's medication regimen. And the NICU attending, I'm not kidding you, is like, I cannot believe I haven't done this more often. Like, I mean, this patient literally flipped day and night from just one day to the other. So I think there's a humongous role there, but I also think there's a humongous role to look at these patients through a rehabilitation lens and say, wait, can they actually go to acute rehab? Like they could go to an LTAC, but we can probably get them to acute rehab. So I think from a prognostication standpoint, a discharge standpoint, looking at someone's neurologic recovery and actually medication profile, this is something that I think is hopefully going to grow in the upcoming years. Because there was a time when specialty rehabilitation centers for spinal cord injury did not exist. Specialty rehabilitation centers for brain injuries did not exist. These patients have absolutely no rehabilitation continuum, and they have horrible functional outcomes. Horrible. I mean, like I said at the beginning, these look like wheelhouse rehab patients. So I think we need to learn and take information from cardiac rehab, from pulmonary rehab, from spinal cord injury rehab, from brain injury rehab, to not only get these patients as functional as we can, but to start to prognosticate and say, how do we compensate and still help you live a really good life, right? Because patients who have C4 complete spinal cord injuries still go to rehab. Why wouldn't we send patients who have remarkable onset disability, even if they're not going to get better, why wouldn't we try to get them into a rehabilitation setting to compensate as best we can for their new onset of disability? So this is where our other physician colleagues are not going to understand what that means, because what they are trying to find is high-risk groups for disability, high-risk groups for disability that respond to therapy, high-risk groups that don't, because you probably shouldn't use your therapy resources on those patients. And that's how they are thinking, and that's also how administrators are thinking. Why did you see these patients? They're not going to get better. Well, by that lens, a C4 complete spinal cord injury doesn't get better. But we still have a remarkable role to serve them. So I think that's the thought experiment, or what I'd leave you guys with is, my hope is that in 20, 30, 40 years, there's specialty hospitals for critical illness rehabilitation. That's how much these folks need us and need you guys. That's it.